Welcome to the Aural Apothecary podcast, authentic chat about medicines, pharmacy and healthcare in the UK.
Pharmacists Jamie, Gimmo and STC take on topical and controversial stories, but keep it edgy yet light-hearted.
Pod guests share their desert island drugs, a career anthem and joyful patient stories. Hi everyone, welcome to the Aural Apothecary podcast. My name is Jamie Hayes. We had such a positive response to our first delve into the Aural Apothecary archives, we're doing it again. Chronic pain and opioids are never far away from the news and are on the Wicked Problems page on the Aural Apothecary curriculum. This time we take you back to February 2022 and episode 9 of series 3, when we welcomed the award-winning pharmacist from Scotland, Tracy Brown. Tracy and her team were recognised for running pain clinics and supporting people with chronic pain in Glasgow. I've had the pleasure of introducing Tracy at a number of national conferences, the first as she presented her work at the PRESCQIPP annual awards event in Nottingham in 2021, and then again at the Scottish Practice Pharmacy and Prescribing Advisors Association conference in Glasgow in 2022. Take another listen, I promise you'll pick up new content. So, where are we up to? Well, with Series 5 we're piecing together something quite special. We hope you like it. For episodes 1 and 2 we were joined by patients, Graham Prestwich and Deborah Duval. Graham talked to us about the need for us all to be project managers of our health and healthcare. And Deborah joined us to share her emotional story as a multiple transplant recipient. And for episode 3 we welcomed Professor Alf Collins into the Aural Apothecary arms. Alf reminded us of the complexities of the person-clinician axis when it comes to shared decision-making. As you listen to Tracy in the discussion from last year, I hope it will open your minds in preparation for our next episode when we welcome Mr. Sean Jennings. Sean is a patient too, who has suffered from chronic pain since he underwent a routine hernia operation at the age of 32. Sean was prescribed opioids and antidepressants for 25 years. He ended up taking morphine, gabapentin, duloxetine and nortriptyline every day for years and years. However, thanks to distraction and mindfulness techniques, along with exercise and movement to manage his pain, Sean is now 5 years medication-free. Join us for our next episode to hear Sean's story. But for now, enjoy this Aural Apothecary archive and remind yourself of the impact Tracy Brown and her team have had on patients with chronic pain in Glasgow.
This episode of the Aural Apothecary is sponsored by OneLessPill.com and Jamie Hayes Executive Coaching.
Welcome to the Aural Apothecary podcast. My name is Jamie Hayes. Coming up in today's episode, we're joined by Tracy Brown. Tracy is an award-winning pharmacist from Glasgow. We will welcome Tracy in a moment as she shares her desert island drug, her career anthem, and recommends a book for the Aural Apothecary Library. Our micro-discussion this week looks at how we go about improving opioid prescribing in primary care, in particular in chronic non-cancer pain. First, let me welcome my two fellow apothecaries. STC is in Bournemouth and Gimmo is in Cardiff. Before I go to them, look, I've been practicing. Which one of these is better? Ladies and gentlemen, please give a generous welcome to the Aural Apothecary Live. Or, how does this one sound?
Ladies and gentlemen, may we please ask that you take your seats, as today's event will begin shortly.
So, we'll be doing our first live show on February the 19th, folks. We would love to see you there. Gimmo, what do you think?
Sounds good. I think we've got a bit of work to do, is my honest assessment. So we spent the last couple of weeks umming and ahhing about whether to go ahead, haven't we, with the live show, because it looked like it might have been off because of COVID. It's back on. So we found a venue, Milk and Sugar in Cardiff. So it's in Central Square in Cardiff on the 19th of February.
So let me stop you there. Just for our overseas audience, Milk and Sugar is take a quick left out of Cardiff Central train station and you'll find it.
Is that where Greg's used to be on Wood Street?
That's a right.
So it's we'll put the booking link up on the show notes and we'll probably be talking about nothing else on Twitter for the next couple of months, but that's exciting. And also, remember Amira from episode 3? I was up last week in Swansea University doing a session with the new School of Pharmacy students, so it's their first intake, I think. And so I spent a bit of time with them talking about quality improvement and medicine safety and stuff. So that was good. What about you, Steve? What are you up to?
So shall we just explain what the format of the live event's going to be and how we're going to take a slightly different tack or not?
Well, I think that by the time this episode goes out, it'll be a sellout anyway.
Oh, right. Okay. I like your thinking there. So if that doesn't happen.
But go on, if there's a few tickets remaining.
We've started to try and take different angles. You might have realised that where we had the medical lawyer on last week. And so we've decided for a long time that we needed to think about the patient angle in relation to medicines. So we have somebody who we know who has unfortunately had quite a lot of care from the NHS recently, some of it for quite serious conditions. And he wants to come and talk about his experiences of having NHS care, some of which included medicines, much of it did. But he also has a very interesting angle because he's an architect. And so he does work looking at how buildings are designed within the NHS. So he's got some really good insights, having spent a lot of time tucked away in hospitals on his own. We think it's going to be a fascinating angle, and we might get further into that, taking patient views about medicines and healthcare generally.
And we will record it as well. So if people can't make it,
will we?
We'll put it out as a podcast.
Yeah, we will try.
We're going to try.
Oh, I thought I was going to be able to be unedited and be able to say what I like.
Live and unleashed, yeah.
Well, listen, I've had a very positive week because of all the news about the Science Festival, as you know, on WhatsApp. I've been super excited about all of that. And then myself and my wife and my daughter, we bought a new flat this week for my daughter, so that's very exciting. And today I think I had one of the nicest compliments I've had since I started working in general practice, so I felt very positive about that. It was a very complex patient. It was a telephone call, actually, a very complex patient with complex physical and mental health, actually. And we had a long discussion, and I did a lot of listening, you'll be pleased to know. And, we ended up with talking about all sorts of things, whether it be about medicines, about weight, exercise, CBT, coaching, the need for bloods. And at the end, the patient just said to me, "Oh, this has been so... I wasn't expecting this at all. What you've said and what you're so wise. You're like Obi-Wan Kenobi." And I love Star Wars. Who doesn't? And I thought, wow, that's a nice compliment, isn't it? So that is a really nice end towards the week. Unfortunately, I was then cycling home about an hour ago, and I've only just calmed down, if I'm honest, because I was listening to a podcast, and it was the DTB podcast. And all right, I'm going to be honest, it's not my favourite, but it is informative. And all I'm going to say is that they were discussing about the new overprescribing report, the Department of Health one in England, and the new National Clinical Director. By the time this podcast goes out, that person should have been announced. And rightly so, they were saying... Can I
stop you midway through? Don't be mean about the DTB.
I'm not being mean.
Okay, good.
I just said it's not my favourite, but it's informative. I listen to it every month. But they were discussing the report, and they rightly point out, well, where's the evidence for saying that 10% of items are overprescribed? And they've always been evidence-based and independent, and I love the DTB for that. But they then went on to say, and I suppose I'm just saying that maybe we've still got work to do, those of us that are working as clinical pharmacists in general practice, because the editor-in-chief, who is a GP, said he had slight concerns about how it was all going to be implemented because, of course, pharmacists are very drug-focused and they may not be best placed to offer patients the alternative advice about non-therapeutic options and consider what's best for patients. And I just exploded when I was cycling home. And I've reflected on it, and he did say slight concerns. And maybe pharmacists do sometimes get drug-focused, but for anybody listening who does that kind of role, we all need to wake up and make sure that people realise that we do listen to people's concerns and we educated as anybody to be able to offer non-therapeutic options, because that is what holistic care is about. And I think today's guest is going to tell us all about that.
Very good. Okay, before we welcome today's guest, look, we had an email. Just a quick email to say I absolutely love your podcast. I stumbled across it by mistake when looking for shared care decision-making articles, and I was so taken with it I've started listening from the very beginning. Playing catch-up now and loving the stories, articles with witty pharmacy humour. It's not a pharmacy podcast. So keep up the fantastic work and Happy New Year to you all. So that was from Alan Hopkins. Alan Hopkins, Senior Pharmacy Technician in Sussex. So thank you, Alan. We need it. Okay, it's my great pleasure to welcome Tracy Brown to the Aural Apothecary. Tracy moved from community pharmacy to primary care 17 years ago. She ran a benzodiazepine step-down clinic for several years. In 2016, Tracy started a pain clinic in one of the GP practices in Glasgow. In 2020, Tracy applied for Scottish Government funding to expand her pain clinic to cover 3 additional GP practices. She now runs the Pain, Teach and Treat programme and is a member of the Scottish Pain Pharmacist Network. In 2021, Tracy and her chronic pain team won the PRESCQIPP Award in Addressing Overprescribing as part of her chronic pain clinic. Her work was also voted as a Silver Award at the PRESCQIPP annual event. All very impressive Tracy, welcome to the podcast. What's on your agenda? What's on your mind?
Thank you very much for inviting me. Really on my agenda at the moment is trying to improve the public awareness of chronic pain and how best to manage it, and also in conjunction with that trying to improve the way that health professionals deal with chronic pain and trying to educate and help people understand more about self-management for chronic pain.
Thanks, Tracy. And so we met Tracy through the PRESCQIPP Awards. That was 6 months ago. It was great to hear your story. Tell us a bit more about the work that you do then in Glasgow.
So in November 2020, I applied for funding through the Modernising Patient Pathways Programme, and really everything kind of exploded from there. I've been a lot more involved in pain management things than I ever have been before. As you said about the Scottish Pain Pharmacists Network, that's recently just been set up, so I'm now a member of that. The Modernising Patient Pathways Programme has got a lot of projects going on throughout Scotland at the moment, and there's been a lot of networking and a lot of learning from one another, so there's a lot of good work going on throughout Scotland. What I personally do at the moment is I run a pain clinic in 3 GP practices. Most of it's actually been run from home during the pandemic and using telephone consultations, and it's really worked out quite surprisingly well. I was a bit worried about it at first, how that would work, but patients have really taken to it. And I think with chronic pain patients, it's really quite difficult for a lot of patients in chronic pain to actually get to GP practices. A lot of the time, it takes a while for them to get up and get ready in the morning, and then the thought of having public transport, getting to a clinic. So you used to have quite a high DNA rate, but the telephone consultations has actually worked really well.
Can you look at DNAs or attendance before pandemic and after and actually see a difference?
I haven't actually measured that, but because I really can just phone a patient at any time during the day, and most of the time during the pandemic it was actually easy to get people in, so I haven't actually measured it, but I haven't had a lot of problems with not being able to contact patients at all.
So Tracy, I've got my notes from when we first met in probably September last year, and I've got a couple of quotes to read back to you, see if you remember these. "Before Tracy and the clinic came into my life, I was giving up and had no hope. Maybe going as far to say Tracy actually saved me that day." That's a stunning quote to receive from your work. Tell us a bit more about that.
Actually, that patient that said that came along last week to record a patient story for me, and it's going to get presented to the Glasgow Health Board. And so it was quite interesting. We went along and she got video telling her story about her. So I said a little bit about the pain clinic, and she told us a lot about how the pain clinic could change the life for her. So basically she was a patient who was in a lot of distress and a lot of pain. She's only young. She's got a young daughter, and she was just crying with pain all the time. She didn't know what was wrong with her. She was looking for investigations to find out what was wrong, but all the investigations were coming back clear. So she was really quite confused, and she came along, well, basically I phoned her, and she said that day was the day that things started to change, and it was really just because I took the time to explain to her what chronic pain was, and that the level of pain didn't necessarily mean that was a significant tissue damage, and that chronic pain was a condition in itself, and really just signposted her to quite a lot of education on chronic pain. She found the Flipping Pain website really useful, and she looked at a lot of that stuff, and really it was just building trust with her and just trying to help her know that I was there and I was going to help her in any way I could. And we just set goals and we worked on self-management techniques. And week after week, every time I spoke to her, she was starting to realise that the medication wasn't the answer, because at the start, that was really what she was looking for. She wanted fixed. She wanted medication to fix her. But as time went on and she understood more about chronic pain and about self-managing it, she realised that the pain medication was actually not working, and it was giving her more side effects than anything. So now she lives her life. She said that she's got her smile back in her face. Her daughter realises the difference that has been made to her, and she's living a fuller life. But she's still got pain, but she just manages it better.
So Jamie, we were at, I'll probably say 2 years ago, and it'll probably be about 5-6 years ago, but it was at the All Wales Medicine Strategy Group Best Practice event a few years ago, and there was a very, very similar story, wasn't there? It was I can't remember the clinicians involved. I'm sorry, I think it was a pharmacist and a consultant.
It was Sue Jeffs was the consultant. I remember Sue being on stage. Yep.
Yeah, and And there was a pharmacist as well, and apologies to her if she's listening, I can't remember her name, but it was a very similar story, and I've heard that story since told by other people involved in pain management clinics. It seems to be an area where, as a result of something earlier on in the system where people have been given the medication and then coming off the medication, it's making a massive difference to people's lives. And that must be very rewarding, but it also highlights an issue in the system, doesn't it, that is probably not being addressed elsewhere.
Listeners shouldn't adjust their headphones at this point. STC is on the call, and he's about to speak now.
I thought I'd said enough earlier, but look, I was really moved by what Tracy said when she won the award at PRESCQIPP, and it chimes though, doesn't it? And like you've just said, Paul. Tracy, I don't know if you've got any advice for anybody who's working out there, because that is the most difficult bit, isn't it? Yes, you need trust to have those conversations, but as you said, it's about patients, people understanding that I talk to people and say, I know what you want and I'd love to be able to give you, and it's what I call light switch therapy, where I flick the switch and the pain goes. But I can't provide that for you because it doesn't exist. And it's that kind of understanding, isn't it? So that they realize that, as you said, they've got to learn to live with it. But a bit like the point about the medicines at the beginning, and we need to look for alternative therapies, is people have turned to them because there haven't been the access to alternative therapies. Now, this is a good point that the DTB made, which is we underinvest, and that's what GPs always say to me, but what can I prescribe? Because I can't prescribe opiates, I can't prescribe non-steroidals in this type of person, but the pain services available to me are not good enough, or they're not extensive enough or accessible enough to deal with this people like the person you've just described, who we've all got tens of, and so we haven't invested, have we? The system hasn't invested enough in pain. Would you agree?
Yeah, I would agree. I feel it's starting to get better with campaigns like, the Flipping Pain campaign and the Living Well with Pain website and things. I think there is a lot more information out there for patients. But also what I'm lucky enough to have in my practice is a links worker. And I find that they're really useful for helping me to do social prescribing with patients, knowing what's on in the local area, finding out whether, a gardening group or anything that I can help direct patients to that are going to help them get out there, get involved, and maybe help their physical and their mental health. So I think at the moment the GPs don't have enough time to do a lot of social prescribing or concentrate on things rather than the medication. But I do think there is a shift towards that way of working. But I think crucial is for the health professionals and for patients to understand more about chronic pain and how to manage it without medication. And I think that's the kind of start of it.
And the best chronic pain clinics that I'm familiar with have got so many different people that work in them. They've got psychologists, they've got acupuncturists, they've got holistic therapies, they've had Reiki therapists. They've got OTs, they've got physios, they've got the whole plethora, haven't you? But that's very expensive in inverted commas. But ultimately, that's what's required, so that otherwise we just don't reach for the prescription. Remember Karen Sankey saying, look, it was just easier to prescribe the antidepressant because it was so difficult to access anything else that could help, even though you knew that writing the prescription probably was the wrong thing to do.
That's exactly it. I work with a lot of really good people. There's a physiotherapist in the practice. There's obviously the GPs, the nurses, the links workers. We're lucky enough in Glasgow to have a Live Active referral scheme, where it's an exercise referral scheme that we can refer patients to. So, and also because of the area I work in, Govanhill being like a really deprived area with a lot of people from minority ethnic backgrounds, there's a lot of third sector organisations in Govanhill that offer lots of support for patients. So I do spend a lot of time signposting patients to things that I think that would help them.
What you described as well is what they talk about in the NICE guidance. I know NICE guidance isn't, I'm not sure if it's extant in Scotland, but there was some controversy, wasn't there, around the NICE guidance, and it was talking about the sort of things that you two have just both talked about. But I can remember some pushback from some of the specialties on it. Is that right?
Yeah, I think there was some pushback. We have like sign guidance in Scotland, but I think we also use NICE as well. But yeah, there was a bit of controversy when it first came out.
But it was about the issue about primary chronic pain and secondary chronic pain. And the point is what I said before, which is that would be great. And we'd actually all love to be able to use non-therapeutic alternatives. But it requires all of those people that we've just described to be able to run it. Gosh, it's a while since we've mentioned the inverse care law. But, you sound like you're working in an area, as you've just described, Tracy, that, you know, there's lots of patients who need all of that support. I'm not saying any other people don't, but, you know, there's the inverse care law in operation, isn't it?
Another area in Govanhill where we have problems with is a language barrier, because there's not a lot of access to a lot of these things in different languages. So that's one of the problems if you're trying to help a patient self-manage their pain, but there's no resources in the languages that they speak. It is easier just to reach for the pen and to write a prescription, and I feel they're not getting the same care as what English-speaking patients are getting.
How many languages did you say were in south of Glasgow?
I can't remember, but it's over 50 in Govanhill area.
So that's the number I've got written down when you said it, 50 languages spoken. Can you tell a listener your sugar mnemonic?
Yes, so this is basically the way that I kind of think about how I run my clinic. So it was like a spoonful of sugar helps the medicine go down, and I was thinking of it along the lines of medicine go down as in reducing medication. So S stands for social prescribing and also self-management, and U stands for both understanding the patient, so understanding what really matters to the patient, understanding how their pain's affecting their life, and also for the patient to understand what chronic pain is, so to educate the patients on chronic pain. The G stands for goal setting, working with patients to try and set up goals, just to kind of help them monitor their progress along the way and give them something to focus on. And A is for accepting that chronic pain is a lifelong condition, and it's a chronic medical condition, but at the same time that you don't need to look for answers for investigations or, you know, find out what's wrong with you. You can treat chronic pain as a condition in itself. And the R is for reviewing patients and also reducing the medication.
No further questions.
I absolutely love that. That's got to be turned into something, hasn't it? It's got to be turned into something. I mean, I suppose to finish off, but it follows on from that, you talked about doing some work around raising or improving the public knowledge and perception of pain. Is that just your patients, or are you looking at sort of wider community type focus?
We're actually setting up, myself and Laura Kennisser, who we're delighted I've actually said her name because she's a big fan of the podcast. She's a pharmacist who also runs pain clinics. Stephanie, who is a physiotherapist. The three of us are developing an online self-management and education programme, and we're going to pilot it in small groups of patients. And it's a 6-week kind of programme. One week we might concentrate on explaining all about chronic pain. The following week we might concentrate on like physical activity or improving sleep. So we're going to pilot that in the next few months, but we're also looking at doing some education with health professionals in Glasgow, like kind of joint working with the secondary care pain team, and also a GP who's a specialist in chronic pain management is going to come along and help to educate the other GPs and health professionals on winter funding for chronic pain. And one of the things that's came out is they've actually got Lorimer Mosley, who's like a well-renowned pain scientist, to come along through like a flipping pain webinar. So that's been like kind of sent out to all the practices in Scotland to let them know about it. So there's 3 flipping pain webinars coming up that the Scottish Government have funded, so that's quite exciting.
That's all brilliant stuff, and I think maybe we should put in the show notes the Flipping Pain and the Live Well with Pain resources for anybody that's not aware of them, because they are, I'm certainly aware with Live Well with Pain, which is excellent.
The Aural Apothecary is sponsored by Jamie Hayes Executive Coaching and OneLessPill.com.
Fascinating stuff, and it's great to hear some insights from north of the border. Tracy, as you might know, one of the other pleasures of coming onto the Aural Apothecary as a guest is to offer us a few things. And the first thing is always a desert island drug, which is not to save you or your family on an island, but is something that evokes a powerful memory. So what would you like to offer us for that?
I don't know if you've had this one before, and it's not pain related at all, but insulin is my one because my daughter got diagnosed with diabetes a few years ago. And obviously it's a life-saving medication for her, but it's 100 years since insulin was first used in patients, and I just love the story about how the very first time it was used in patients, they injected it in the first patient went round the ward, and then by the time they got to the last patient, the first patient had already had a significant improvement. So that's my drug choice.
Brilliant. So I'm going to go out on a limb here, and I'm going to say, wasn't the inventor of insulin Scottish?
I was just thinking that. It was in Canada, wasn't it? But he was Scottish.
Yeah, it was in Canada, but I don't know if he was Scottish or not.
I think he was, because I used to have an expert patient come to talk to them about what it's like actually living with diabetes. So your daughter would be able to do such a session, and I'm sure you could equally do that. So yeah, it's a classic drug, isn't it? It is a lifesaver, but it's on that spectrum of, but you do need to be very careful with it, because too much is also, unfortunately, can be fatal. So in a therapeutic sense, it's a beautiful example of a medication.
We have had it before, haven't we?
We have, I
Have
think.
you?
Yeah. But that's fine. That's fine.
For very different reasons, if I remember rightly. Do you remember who it was?
I'm going to go Angela Carrington
Yes.
from Northern Ireland.
Yes, I think it was too. So that's absolutely fine, because it's about something that's powerful and it evokes a memory to you. So as we said, insulin is a great drug. So we'll definitely take that. Thank you very much. And thank you for your daughter allowing us to talk about that. What about a career anthem then, Tracy?
This one actually relates to what we were talking about earlier on. It's quite a weird choice, but I was going to go for A Spoonful of Sugar Helps the Medicine Go Down.
That's great.
That's from a musical film, isn't it?
Yeah, it's from Mary Poppins.
Yeah.
Come on, Steve, from a musical film. One of the most famous films ever.
Never seen it, fortunately.
Is there a reason then, Tracy? Or just like the medical connection?
Because of what we were talking about earlier on, the spoonful of sugar helps medicine go down, but also because I like the story about why the song was made in the first place. It was because one of the songwriter's sons had came home after having his polio vaccine, and the father had said to the son, "Oh, how was it? Was it painful?" And he said, "Oh no, because it was just put on a sugar cube and I swallowed it." And then they went and they wrote the song the next day. And I also like when you look into what the song actually means, and it talks about how if you make something more fun, or if a pleasant experience can help make the bad experience better. And I think that's what you do when you're self-managing pain or helping patients self-manage their pain. If they can make their life wider and have more going on in their life, then it helps their mood and then it helps their pain as well. So I thought it kind of links in quite well with that.
Oh, I love that. And I think I'm right in saying, and I'm not sure if it was a Welsh strategy or a UK-wide strategy, there was a pharmacy strategy about 20 years ago called A Spoonful of Sugar. And a lot of the stuff that we see today was first mooted in there, sort of independent, supplementary prescribing. I think they were probably talking about the wild idea that pharmacists would work with GPs. It was all in there, I think, Spoonful of Sugar.
Yep, it certainly was.
What was that? Was that Audit Commission or was it a national
Yes,
strategy?
I think it was the Audit Commission before it turned into the CQC, Care Quality Commission. Very good. Well, we'll definitely take that. Who doesn't like Mary Poppins? And as we always say, there is actually a Aural Apothecary Spotify playlist, and so we always update that every time we have a new episode. So Tracy's song will go into that. And the final thing we're after is a book recommendation for the listener to go into the Aural Apothecary library. So what did you make of this?
The book that I would like to recommend is Explain Pain, and that's actually written by Lorimer Mosley, who I mentioned earlier on, and also David Butler. So it's written with like a kind of pain science background, and it really explains all about how pain works in the body, and it gives lots of really good examples of different experiments and things that have been used to kind of explain how pain works. And it can be used along with patients, or you can just read it. It's good for health professionals and patients alike.
Excellent. Okay, so Explain Pain by Lorimer Mosley and David Butler.
That's it.
Right, excellent. Well, I hope you had fun thinking about those three things. I know sometimes the guests say they do like that part of it, even though you have to think. So great choices as ever. I think it's me again on the micro discussion, and we thought, seeing as Tracy was on, we should talk about something that was relevant. So this is a paper that's by a large group of authors, but Sue Wood is the lead author, from the Leeds Institute of Health Sciences. This was taken from the British Journal of General Practice in October 2021, and it's about general practice responses to opioid prescribing feedback. It's actually a qualitative study, so they interviewed people who worked in practices, whether they were GPs, pharmacists, practice managers, around a scheme that was running in Yorkshire which was allowed an evidence-based bi-monthly feedback intervention to try and help reduce opioid prescribing. And that happened for 316 practices in West Yorkshire over 1 year. And so what the study was trying to do was trying to find out, using something called normalization process theory, which brought me out in a cold sweat, having done qualitative work, trying to find out and understand how the staff received and responded to the feedback intervention and what came of that and their views of it. Who'd like to kick us off? Tracy?
Before you start, Tracy, if there's any patients or people listening to this now, can you just tell us what opioids are we talking about out there in practice?
From the kind of less strong ones like cocodamol, dihydrocodeine, tramadol, up to like your morphines, your oxycodones, your fentanyl.
Thanks, because we talk about opioids all the way through, and I just thought let's mention a few drug names here for people.
Okay, and also maybe then just before Tracy kicks off, for the non-health professional listener, you have to remember that this stat passed just last year where the US, for example, had 100,000 drug overdose deaths in 2020 due to opiates. And actually, in the last 20 years in America, there has been 1 million, I repeat, 1 million drug overdose deaths due to opiates.
So I had a look at the paper, and it was really interesting to see how the bi-monthly feedback motivated the GPs to continue working on opioids. But the bit I liked about it was when one of the GPs got quite excited about the patient feedback. The patient said, "Gosh, I'm a changed person. I can focus on things. I want to do stuff. I've got that enthusiasm. Otherwise, I was just a blank person." And I thought it was quite good how the conversations about opioids every couple of months, the GPs talking about what patients were saying and the feedback they were getting kind of motivates them to continue with the work.
Thanks, Tracy. I'll just add to that is friends, colleagues, they ask me, well, why don't you just change things then? Why don't you just stop people doing things that you don't want them to do? And so I said, well, that's, behavioural change isn't like that, is it? And so this, for me, I've read it a couple of times after Steve sent through on the WhatsApp group to say, need to read it a few times to get the most out of it. But it just shows you the level of detail that we need in addressing some of these behavioural change, so it's not as simple as saying, don't do this or please stop doing that. And so they go into huge detail. But the feedback, is a quote from Don Berwick, I'll use feedback for improvement, not for judgment. And so that's part of it that comes out of it. And so they identify the themes of deciding to act, engaging the team, flexibility in responding. So there's a huge autonomy thing there, isn't there, of being able to allow the practice and the team to decide what resources they use and how they go about it themselves rather than being told, do this. They talk about the challenges. And then the interesting one is around practice gatekeepers. There's some really simple stuff there as your report ends up in the bin. Somebody in a central office somewhere, away from the front line will have gone to a lot of, effort and expertise to develop something. And something as simple as posting it to the practice, that being actioned by one of the team in the practice could result in that going straight in the bin. That's our world, Gimmo, isn't it? In that sort of improvement world.
Yeah, and you picked up on what I was interested in. It's the methodology, isn't it, that was behind this. So what they did was they fed back practice-specific comparative feedback reports that presented overall opioid prescribing, as well as that for specific groups at risk of long-term or strong opioid prescribing. So basically they gave personalised regular feedback to the practice and then used, it says here, evidence-informed behaviour change techniques were embedded to enhance effectiveness. Do you remember the antibiotic stuff we did, or we looked at a while back? It was the same sort of stuff, wasn't it? It was feeding back prescribing data to practices with some behaviour change stuff, precisely worded letters, authoritative figures, all these techniques that were designed to sort of enhance the impact of the feedback. So I really like this paper, but I mean, it was a coincidence, almost happy coincidence. It was about opioids for today's conversation, but it could have been about any chronic drug that's prescribed, really, couldn't it?
Wait a minute. I don't believe in coincidences. It's not just thrown together, but what you're about to say is exactly the point here, isn't it? So this was from 2016, right? But even in 2016, opioids, as big an issue as they were, and the people that in their feedback, because they did I should have explained, but it is quite complicated, but they did semi-structured interviews and they used this particular theory. What people said is, one, actually, look, it was a time where they realised that opiates were a big thing, and we discovered that for non-cancer pain, maybe they weren't that effective, and actually there was this risk of both serious harm, but also lots of other harms associated with it. And so therefore, if you like, the Daily Mail was already talking about it. So I can tell you from my experience, patients would bring in and say, well, I want to talk to you about coming off my dihydrocodeine because I read it. So you already had some patients that were informed and wanted to do it, which makes it much easier. But I'm sure Tracy will concur with me that there's plenty of other people who just, like a wall comes down, and some of the GPs in here's feedback is, well, I just was worried that I was going to get into a difficulty with the patient, who's my patient, and therefore my relationship with them would break down because they thought I was trying to take things away from them. And the other thing I was going to say was that the problem is that this was just about opiates, and that's a big issue, and we definitely need to look at it. But remember, at the same time, they're not only getting all this stuff about opiates, they're getting the same thing about diuretics, they're getting the same stuff about anticoagulants, antiplatelets, non-steroidals. So whether it's PINSA in the UK or EPAC data, and, you know, I'm involved in some of this stuff and I'm a big believer in it, but it talks about you need to have somebody who's going to champion it in the practice. I know this is obvious, but when we've talked in the past about, it's not about the innovator, it's about the adopter. And if you don't support the adopter with techniques and ways to try and do it, it's actually, like you said, Jamie, when our mates say to us, well, why don't you just do it? It's really quite hard. And this focus is one thing, but you've got all these other focuses going on at the same time. And I suppose I would go back to, certainly in England now, a lot of these things should fall to the pharmacy professionals who now work within the PCNs, and they need to work it out, don't they? So it's not just the opiates, but it's all the other things I've just described that they also need to do, and you can't rely on all the same people to do all the same things. James, I know you're dying to say something.
Oh, no, I was going to wait for Tracy to come in. It reminded me, like Gimmo said, reminded me of the STAR study where I was lucky enough to work with Professor Chris Butler and Professor Steve Rolnick, who is the motivational interviewing guru. So we haven't talked much about motivational interviewing. Do you use that much, Tracy, in your work?
I haven't actually did any training or anything on motivational interviewing, and that is something that I've actually just today put my name down for, which is quite interesting. But I think, like what you were saying, Steve, the GPs are sometimes scared that they're going to break down the relationship with the patient if they broach the subject of reducing pain medication. But I think it's all about the approach. And I learned quite early on that if you go welcome a patient in and say, right, we're going to talk about reducing your medication, then you get that wall up straight away. And I think sometimes it's about the way you sell it to a patient. So when the patient comes in, speaking to them and, you know, building trust with them, really, really listening to them, finding out what's going on with them, and trying to maybe even help other aspects of their life. So it might be that they're on a drug that's not making sense to them, or that they're on something that's causing them side effects. So sometimes my first consultation is not actually anything about the pain. It's helping them do something else that's going to, you know, help them. And then I move on to pain. So I maybe in the first consultation will touch on it, and then it's kind of drip feeding it as you go along.
So if I go right back to when I was getting a little bit hot under the collar about the DTB podcast, is that this is a fantastic example of, like you just said, if you just go straight for the drugs, whoop, up come the wall and you've got no chance. So whoever you are, pharmacist, doctor, nurse, physio, you've got to build that relationship, haven't you? And so I think this is a really good example. And I'm sure you're aware of Emma Davis, who's a pain pharmacist like yourself, I know she's a co-founder of Live Well with Pain. And she recently was talking to her because she's coming to talk on PRESCQIPP about dealing with pain in structured medication reviews. And she said something that was so precise, and I really got it. And I wanted to say this now, because this paper was essentially about analgesic stewardship, okay, with like antimicrobial stewardship. But pain management, what you're doing, Tracy, they're actually very different, aren't they? And what you mustn't do is conflate them, because analgesic stewardship is one thing that needs to be done, but chronic pain management is something different, and that has to be done differently.
Yeah, I think you're absolutely right, because I don't really go about my clinic in terms of trying to have in my mind, I want this patient off this medication, I want them off whatever. It's all about finding out what it is that matters to them, how I can help them manage their pain. And then as a byproduct, once they maybe start to understand pain and start to do some of the self-management, then they start to consider, okay, I might reduce my medication. So it is a different approach from the kind of typical deprescribing that a lot of pharmacists would do. So I always say that to other people that are thinking about doing pain clinics, there's no point in sitting trolling through all the notes and planning what you're going to do with this patient, because they're going to come in and tell you something completely different from what you're expecting. So you really just have to listen to them and find out what it is that they need.
Tracy, I've just looked up my motivational interviewing definition, which will come back to something we've said on the podcast previously. Motivational interviewing, which you will really enjoy and it'll be really valuable for you in your work, helping people get unstuck and free up their own resources for change. And so, when you do it, again, Professor Steve Ronak is the godfather of motivational interviewing. It's fascinating and you will really enjoy it.
Who also on the podcast mentioned about people getting stuck?
It was Professor James McCormack.
And he was talking about
depression. Okay, thanks all. A big thank you to Tracy for joining us on the Aural Apothecary and for sharing her stories, her desert island drug, her career anthem and her book for the Aural Apothecary Library. Coming up next time and for our final episode of Series 3, we'll be joined by Dr. Pete Turton. Pete is a long-standing trainee in both anaesthesia and intensive care medicine, known for his cameo role in the Placemat podcast, and perhaps more importantly, a runner-up in his heat in the Krypton Factor. Pete describes his interests outside medicine as paddleboarding, longboarding, and boring anyone who'll listen about the Eurovision Song Contest. We look forward to catching up Pete next time on the Aural Apothecary podcast. You can contact us via Twitter at Aural Apothecary. We're on LinkedIn and you can email us at auralapothecarypod@gmail.com. Over to Gimmo now for the final ingredient.
Okay, so thank you, Tracy, for that. It was fantastic. I really like the spoonful of sugar, both the song and the mnemonic. I really like that analgesic stewardship versus chronic pain management, Steve. So I'll give you a point as well tonight.
That's all Emma's, and I always give due acknowledgement.
Hi, Emma, if you're listening.
I'm chatting to Emma next week, so I'll mention it.
There you go. We love due acknowledgement on the Aural Apothecary podcast.
So, final ingredients. So I wanted to chat about heavy metal toxicity and mortality. Actually, I mentioned Amira early on. Remember Amira back in episode 3 talked about heavy metal toxicity and heavy metal in teas? Well, heavy metal was covered in a recent article in the BMJ where they looked at heavy metal toxicity and mortality. More specifically, they looked at the association between the density of heavy metal music bands and cause-specific admissions and mortality as a population-based cohort study. That's right, heavy metal bands. And on this podcast, we like to look for alternative to medicines. And so I think we found another. You remember that both Dr. Mark Porter and Dr. Sally Lewis talked about their love of heavy metal and how it helped them through some difficult times in their life. Well, it turns out there could be something in it. The study found a reduction from hospital admission and mortality from all causes: internal causes, alcohol attributable causes, accidental injury, violence, suicide and self-harm, and mental health related causes. Vibrant local heavy metal scenes might help to promote health through healthier lifestyles, better coping mechanisms, and a strong sense of community. This was in the BMJ Christmas edition, so read it for yourself and of course take it with a pinch of salt. But there you go. If you want to get happy, get rocking.
This was a 3 Apothecaries production. Sound engineer Jimbo Slough. Original music Jamie Brewster. Artwork by David Baker.
Thanks for listening to the Aural Apothecary podcast. Do not listen more than 8 times in 24 hours.
This episode of the Aural Apothecary is sponsored by jamiehayes.co.uk.